Hello and welcome to all. This is Ankana, the assigned moderator from IJCP Group. I wholeheartedly welcome all the delegates across the country. We are fortunate enough to get supported by the doctors. Thank you all the doctors for taking out time to join us today. Now I am taking this opportunity to welcome today's master doctor, none other than the eminent speaker, Dr. Aviral Roy, sir. Sir is the consultant intensivist at Akashi Healthcare, Kolkata. Now, with the help of Dr. Aviral sir and his wonderful insights, we will be taking a close look on today's topic, which is secondary prevention of stroke, antiplatelet therapy, and beyond. Without any further delay, sir, I would like to hand over the session to you. Kindly proceed with your topic. Over to you.
Thank you, Ankana. And thank you, everyone, for joining and taking time out on what I know is a Saturday evening and the weekend is approaching, is here, in fact. And I promise you, I will not be long. Okay. So I'm a critical care, neurocritical care, and internal medicine consultant with Akasi Healthcare. And I have no disclosures to report. So, what's going to be our agenda for today? We're going to take a quick look at the epidemiology of stroke and I'll get some definitions. We're going to look at some diagnostic modalities and testing to prevent secondary stroke. We're going to look at lifestyle modifications that have shown to reduce the frequency of stroke. And then finally, like we said, we're going to discuss pharmacological measures for management of stroke, secondary management of stroke. These are the things we will not cover. We will not cover, actually, we will cover intracranial, but we will not cover extracranial large vessel occlusion. Things like LV thrombus, Moyamoya disease, congenital heart disease, carotid tumors, cardiac tumors, aortic tumors, and other rare causes of stroke, just because then the talk becomes really long and it is already very, very long. So without any further ado, let's start with the epidemiology of stroke. And we'll first begin with some definitions. So we all know what a cortical stroke is, right? We know it's a cortex stroke, but we don't understand what's a lacunar stroke. So what's the definition of a lacunar stroke? A lacunar stroke or a lacunar syndrome is a patient who has either on CT or MRI a a subcortical stroke measuring less than 1.5 centimeters in size, or they have the symptoms of a stroke but will have a normal CT or MRI. And why does this happen? Very often because the size of the stroke is smaller than the size of the cuts on our CT scan. So you will see either a normal CT or MRI, or you will see on CT MRI a subcortical stroke that is not involving the cortex, less than 15 millimeters or 1.5 centimeters in size. These are usually due to small vessel disease in the brain. What's a cardioembolic stroke? It's a stroke attributable to an arterial occlusion from an embolus that we assume has arisen from the heart. The clinical and brain imaging findings are often very, very similar to those seen in large vessel stroke or large vessel atherosclerosis. The evidence of a previous TI or stroke in more than one vascular territory will often support a clinical diagnosis of a cardioembolic stroke. Then, what's a cryptogenic stroke? A cryptogenic stroke is imaging confirmed stroke from an unknown source. That means you have done your workup and you cannot identify the stroke location through diagnostic assessment. That at the minimum you have done arterial imaging. What arteries? You're looking at the carotid artery, so that's the external vessel supply to the brain. Intracranial artery, so you've done either a MRI or a MR angiogram or a CT angio of the head and neck. Echocardiography to rule out cardioembolic origin. You have done extended rhythm monitoring to ensure that patient does not have atrial fibrillation. And you have done key laboratory exercises with lipid profile and HbA1c to rule out hyperlipidemia and diabetes mellitus. Stroke caused by large artery atherosclerosis, that is atherosclerosis of large arteries. What are the large arteries as far as the brain is concerned? You have the extracranial extracranial carotid artery, the internal carotid artery. You have the intracranial internal carotid artery. Then you have the cerebral artery, MCA, anterior cerebral artery, the ACA, the posterior cerebral artery, the PCA, and finally the vertebral artery, the basilar artery, and the posterior cerebral arteries. An ischemic stroke in the vascular distribution of the major intracranial or extracranial arteries of more than 50% stenosis or occlusion. So, if any artery is more than 50% stenosed and you have a stroke in that artery's uh, territory, it is assumed to have come from that artery. Clinical findings, including those of cerebral cortical involvement or brainstem or cerebellar dysfunction. Lesions of more than 1.5 centimeters in size are considered due to large artery atherosclerosis, and diagnostic studies should exclude potential source of cardioembolic origin. So you have to also rule out cardioembolic origin. What is this? Again, you make out there's no left LV thrombus, you make sure no left atrial thrombus, no AFib, and you make sure the neck vessels, the large vessels of the neck, show no evidence of plaque rupture and thromboembolism. You make sure there is no infective endocarditis. So we'll take a quick look at the epidemiology of stroke. What is the Indian data? As we can see, this is done in 5 cohorts. It's a population-based stroke registry. It's done in Cuttack, Kachar, Tirunelveli, Kota, and Varanasi. As you can see, stroke is most commonly seen in the older age group, 64, 60, 62. It is predominantly male, 59 to 41%. Though that being said, this was also due to, remember, females tend to have a little bit of protective effect due to estrogen. Depending on the area you stay in, stroke can very often be more rural than urban. This is very often due to the fact that more than 60% of our population indeed does stay in the rural areas. Risk factors are diabetes, hypertension, and of course, tobacco use. And if you see the type of stroke, and this is kind of preserved, most common it is ischemic between 75 to 85%. Some of them might be hemorrhagic, 20% to 25%. In some areas up to 35. This is more common in, if you will look and see places where you have high amount of hypertension, you might also see high amount of hemorrhagic stroke. And undetermined basically were places where they were unable to get imaging done on these patients. About 16 for 40% of patients who have stroke will often die within 28 days of onset. So, it's not a benign condition, definitely not a benign condition, and a condition with serious mortality in addition to the significant morbidity that we know of. This is international data taken from AHA. They see about 90%, 88% ischemic, 10% hemorrhagic, and 2% as subarachnoid hemorrhage. Of ischemic stroke, 77% is what you consider large vessel stroke, and only 23% is lacunar. Of non-lacunar stroke, so that is basically the large vessel occlusion, about 35% is cardioembolic. A very high percentage, 45%, is cryptogenic, which means despite extensive analysis, we are not able to figure out what is the cause of this stroke. 17% is large vessel occlusion, and 3% are other causes. And of cryptogenic stroke, about 50% is ESUS and 50% are non-ESUS. What is ESUS? Is embolic source of embolic stroke of undetermined this thing source. So that is, you do not know where the stroke has come from. We will be going over some data, and I'll just show you what the data looks like and what the colors will mean. So even if you do not remember anything else, if you see the color, you will know what this level of data is. So class A data, or level of strength of recommendation, right, is class 1 is strong, so this will be green in color. It is recommended, or it is the benefit is much 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 better than the risk. If you see a yellow color, it is a class 2A or a moderate strength recommendation. Benefit is significantly more than risk. 2B is weak recommendation, where the benefit may be slightly more than risk. And if you see a orange color, it is there is no benefit. So you might say it is the same, or it is equal, or it is not recommended. Okay. Level A data is very, very high quality data. Level B data from randomized study is moderate quality data from randomized studies or RCTs or meta analysis of RCTs. Level B NR, which is non RCT data, is from moderate quality evidence from well executed non randomized controlled trials or meta analysis of non randomized controlled trials. Level C data is limited data, so it is not very, very high quality. And if you finally you get level C over here, expert opinion, which is basically a consensus of experts, and it is very often due to mechanistic or physiological um, concordance or understanding of the data. With that in mind, let's quickly move over to diagnostics and radiology in order to for secondary stroke prevention. What are the things that you must do? Level 1 evidence, green. In a patient suspecting of a suspector having a stroke or TIA, an ECG is recommended to screen for atrial fibrillation and atrial flutter. So why do we do the ECG? We do ECG to make sure they're not in AFib, because this would make it a cardioembolic stroke. Remember? Okay, good. Level another green, so high quality of evidence, green recommendation. In a patient with an ischemic stroke or TIA, a diagnostic evaluation is recommended for gaining insight into the etiology and planning optimal strategies for preventing recurrent stroke, with testing completed or underway within 48 hours. So, what does this mean? You want to consider getting carotid artery Doppler. You want to get a CT scan, angio of the head and neck. You want to get a echocardiogram of the heart. So you want to do quick, you want to do this, you want to get a lipid profile, you want to quickly get an HbA1c, you want to get a homocysteine level. Why do we do this? Within 48 hours, so we understand the cause of the stroke and we start a strategy immediately to mitigate secondary causes. In patients with symptomatic anterior circulation cerebral infarction or TIA who are candidates for revascularization, non invasive cervical carotid imaging with carotid ultrasound or CT angio or or MR angio is recommended to screen for stenosis. That means in people who you want to do revascularization, you want to take a look at their anatomy immediately. In patients suspected of stroke or TIA, CT and MRI is the recommended imaging to confirm diagnosis of symptomatic ischemic cerebral disease. So all these are level 1 evidence. So these things we already do. Fine. In patients with confirmed diagnosis of ischemic cerebrovascular disease, blood tests that you should do in CBC, PT, PTT, random glucose, HbA1c, creatinine, fasting or non-fasting lipid profile are recommended to gain insight into risk factors for stroke and to inform therapeutic goals, which means you want to understand what the underlying risk factors are and immediately initiate risk factor modification. These are some yellow recommendations, which means their risks are significantly more than benefits. Um, 1 second. Yeah. What are these? In patients with cryptogenic stroke, echocardiography with or without contrast is reasonable to look for potential sources. So, what are you looking for? You're looking for PFO. You're looking for LV thrombus. You are looking for left atrial thrombus. In cryptogenic stroke who do not have a anticoagulation contraindication, you can do long-term rhythm monitoring with a mobile cardiac outpatient telemetry or implantable loop recorder. What does this mean? Consider getting a Holter, 24-hour or 48-hour Holter initially as a screening. If those are negative, consider there's something called implantable loop recorder, which you just put under the skin, and that stays for almost 30 days, or in some cases up to 60 days. It's called event monitor. So every time you detect something, it takes a long image, and you will very often be able to catch a episode of atrial fibrillation. In patients suspected of ischemic stroke, if initial CT or MRI does not demonstrate infarction, you can get a follow-up scan. In patients suspected of TIA, if follow-up imaging does not show symptomatic infarct, you can get a follow-up MRI. Why do you do this? To predict risk of early stroke and to support the diagnosis. In cryptogenic stroke, You should test for inherited or acquired hypercoagulable states, bloodstream or CSF infections, infections that can cause central nervous system thrombosis. You should look for drug use and markers of systemic inflammation and genetic diseases. Why are you doing this? Looking for secondary causes of stroke or rare causes of stroke and to prevent secondary strokes. Finally, in patients with ischemic stroke or TIA, non-invasive imaging of the intracranial large vessel arteries and imaging of the extracranial vertebropatelet system with MRI or CT can be effective to identify rare causes such as atherosclerotic disease, dissection, moya, and other relevant etiologies and vasculopathies. 2B recommendations. These are slight benefit over risk. In patients with ischemic stroke, and for whom you're requiring or planning anticoagulant therapy, a CT MRI before therapy may be considered if you're to rule out hemorrhagic transformation. In patients with ESUS, so that is embolic stroke of undetermined source, you can get a TEE, cardiac CT or cardiac MRI to look for uh, cardioembolic origins of your stroke. And in patients with whom you're considering getting a PFO, might want to get a transcranial Doppler during the procedure to look for embolus detection while this is ongoing. Now, this is a predominantly a majority of your guidelines for diagnostics and imaging. And why do we do this? Because a meta-analysis from 2014 found the proportion of patients diagnosed with a post-stroke atrial fibrillation in the emergency room by ECG was about 7.7%, so 8%. About 3% of patients with an acute stroke may also have an acute MI that could be an NSTEMI or a STEMI. The risk of stroke within 90 days after the first stroke is about 5%, but depending on the mechanism can go as high as 10%. And in patients with recent minor focal non-motor, non-speech neurological deficit, which means visual disturbances, maybe having a short run of a seizure, having visual disturbances, auditory disturbances, DWI imaging, so diffusion weighted imaging MRI, detected acute infarction about 13% of patients. And there was a 6 times increase in the risk of recurrent stroke at the end of 1 year. So, this is why we do all these tests because you can have up to a 13%, 14%, a 14% chance of stroke is 1 in 7. So, 1 in 7%, 1 in 7 people who have minor focal non-motor non-speech neurological deficit will have a recurrent stroke within 1 year. Then let's come to risk factor modifications. And what are the risk factors that you can modify? We're first going to discuss vascular risk factor modification. So what is this? Have vascular hypertension, right? But that's the one that most commonly affects your blood vessels. So green recommendation level 1. In patients with hypertension or experience a stroke or TIA, treatment with thiazide diuretic, angiotensin ACE inhibitor, ARB, is useful for lowering BP and reducing recurrent stroke risk. Remember, it is not so much the agent that you use, rather it is the amount of blood pressure reduction. And that brings us to the next point. You want a blood pressure reduction of about less than 130/80. In patients with stroke or TIA, green recommendation, you want to take an individualized drug regimen to account patient comorbidities, pharmacological class, and patient preferences. So, what does this mean? It means if you have a patient who has existing history of heart failure, and along with that now has a stroke, for example, you might want to choose a beta blocker, a ACE inhibitor, and ARB, or something like spironolactone or finerenone to control the blood pressure, something that assists their heart failure as well as your pressure goals. Or for example, a patient who say might have BPH, you might want to consider an agent such as an alpha blocker in that case, which will help with both the BPH symptoms as well as the blood pressure. A yellow recommendation over here. In patients with no history of hypertension or experience of stroke or TIA and have a blood pressure of more than 130/80, you'd want to start hypertensive medication to reduce the risk of recurrent stroke, intracranial hemorrhage, and other vascular events. Nutrition guidelines. In patients with stroke and TIA, you want to counsel them possible for a Mediterranean type diet, which is high in monounsaturated fats, plant-based foods, fish consumption with something like virgin olive oil or lots of nuts, in preference to a low fat diet to reduce the risk of recurrent stroke. So you want to give them a diet that's strong in in unsaturated fatty acids, and you want to give them a lot of fiber consumption and a lot of nut consumption, which is shown to reduce the risk of disease of furtherance of atherosclerotic disease. So the Mediterranean style diet is shown to reduce the progression of atherosclerosis, and that presumably will reduce the risk of recurrent strokes in them. Also, in patients with history of stroke or TIA and hypertension, you'd want to control their salt intake to less than 1 gram per day of sodium, 1 gram of sodium or 2.5 grams per day of salt to reduce their risk of cardiovascular disease. So, what I tell my patients is about 3 grams of salt per day is what they're allowed to take. What is 3 grams of salt? That's the amount of salt you can take in a day that they normally put in food, but you're not allowed to add extra salt to your food. So, summarizing diet, you want a high you want a diet that's high in monounsaturated fatty acids, okay, high intake of plant-based fruits including fruits, vegetables, legumes, whole grains, and we see whole grain, whole wheat, whole cereals. I preferably consuming fish or white meat if they are a meat eater. Low consumption of meat products, especially red and processed meats. You can consider a little bit of red wine consumption, though that data is a little bit not panning out as well as it used to. Moderate consumption of milk and dairy products. This is very important. Discourage soda with sugar. So, sweetened soda, pastries, sweets, commercial bakery products, and spread fats. What are spread fats? It is that butter, it is that margarine, it is that cheese which you can put on your bread. We don't, that's not recommended. So this is a Mediterranean diet. And what is the DASH diet, which is the dietary approaches to stop hypertension? Limited saturated fat, cholesterol, and emphasize on nuts. Emphasize fruit, vegetables, and legumes. Emphasize whole grains. Limit red meat and processed meats. Emphasize fat-free and low-fat dairy. Limit sweets, added sugar, salt, and sugar sweetened beverages. So what I basically tell my patients is you're not allowed to have dessert because dessert is just added sugar. Correct? Sodas are a no-no. You can consider low-fat milk. You can consider white meat. You can chicken, fish. If you're in the West, turkey, whole grains. Avoid white rice. Avoid maida. You can consider full wheat, roti, millets, then foods of that sort, and fruits and vegetables in appropriate diet. That's of course recommended. Physical activity, and this is something that a lot of us tend to forget. So it's very important to give your patients as much physical activity as they can tolerate. In patients stroke or 2 are capable, of course, of physical activity. You want a minimum of 10 minutes 4 times a day of moderate activity or vigorous intensity aerobic activity of 20 minutes twice a day to lower the risk of recurrent stroke. In patients stroke or TIA, there's a yellow recommendation. Who are able to increase physical activity, engage in an exercise class and includes counseling to change physical activity and behavior. This reduces cardiometabolic risk factors. For patients who have deficits after stroke who have impaired their ability to exercise, you want a supervised exercise program with a healthcare professional. So that could be a rehabilitation person, can be a physiotherapist or a cardiac rehab for secondary stroke prevention. And finally, in patients with stroke or TIA who sit for long periods of time, it may be reasonable to recommend breaking up sedentary activity with 3-minute intervals of standing or light exercise, so that's walking, every 30 minutes or so to improve cardiovascular health. Smoking cessation. Every single person who has a stroke, you should counsel to stop smoking. Patients with stroke or TIA who continue to smoke should be advised to reduce their smoking intake as much as possible. In patients stroke or TIA, you want them to avoid, that is passive smoking, that is other people are smoking and they're inhaling the air. So this is straightforward. There's not much to think about it. This is substance abuse recommendations. People who smoke, who with a stroke or TIA, who drink more than 2 drinks a day for men and more than 1 drink for women should be counseled to reduce their alcohol consumption or stop it entirely. If people do amphetamines, cocaine, and these patients and in patients who do IV drugs who have endocarditis, of course, this goes without saying, we should stop it. And those who have trouble with quitting, you might want to enroll them in specific programs to help with their drug dependency, to help to get them quit. You want to get them to rehab or recommend them to go to rehab as far as possible. Remember, there are certain studies that there's a study that shows that using cocaine will increase your list risk of a stroke 11x. So people who use cocaine have between 11 to 14 times, that's multiplied, higher risk than the baseline population of having a stroke. Finally, lipid and cholesterol management. Level 1 green evidence. In patients with ischemic stroke with no known coronary artery disease, you want an LDL target with LDL-C, that is directly measured LDL, not calculated but core LDL or measured LDL of more than 100. You want to start atorvastatin 80 milligrams. Ischemic stroke or TIA with intracranial carotid coronary disease, your LDL target is less than 70. You want to use a statin and or ezetimibe. Remember, they two work slightly differently. Statin works by is a HMG CoAce inhibitor. It reduces the liver production of cholesterol. Ezetimibe is a drug that blocks the intestine's ability to absorb cholesterol. You use these drugs either individually or as a combination to get to a goal LDL of less than 70. In patients with ischemic stroke who are very high risk for ASCVD, that is atherosclerotic coronary or cardiovascular disease, or how to understand if they have a stroke plus multiple high risk conditions, who are taking maximum statin and ezetimibe therapy, and the LDLC is more than 70, you can consider starting them on PCSK9 inhibitor therapy to reduce the risk of further coronary and cerebrovascular events. People who have a stroke or TIA and who have hyperlipidemia, you should be measuring their fasting lipids about every 4 to 12 weeks after statin initiation, and after that every 3 to 12 months to determine adherence to protocol and compliance with therapy, and further modification of management or whatever you want to do to modify their drug therapy. What are conditions that are considered major ASCVD events? Stroke, ACS. ACS includes MI and symptomatic peripheral vascular disease. These are considered high risk conditions. Age is the highest risk factor for atherosclerotic disease, more than 65. Heterozygous familial hypercholesterolemia, history of need of bypass surgery or PCI. Apart from this, diabetes, hypertension, CKD with the chronic kidney disease stage 3 or more, and if the patient is a current smoker. All of these are considered high risk factors for ASCVD, which is atherosclerotic cardiovascular disease or cerebrovascular disease. What are your triglyceride recommendations? Patients stroke or TIA with fasting triglycerides of between 135 and 499 and LDLC that is under 41 to 100 on high intensity statin, you can consider therapy with icosapentadyl ethyl to 2 grams twice daily to consider reducing the risk of stroke. Why no risk of pancreatitis, atrial fibrillation, or heart failure? Because icosapent ethyl can increase the risk of pancreatitis, atrial fibrillation, and heart failure. In patients severe hypertriglyceridemia, that is more than 500, you want to identify and address cause of hypertriglyceridemia. That is, you want might want to cause a low fat diet, avoidance of refined carbohydrates and alcohol, consumption of omega 3 fatty acid, and if required to prevent pancreatitis, you can consider fenofibrate or fibrate therapy. Level 1 evidence for obesity: weight loss is recommended to improve your ASCVD risk profile. All of this is green level, green quality data. Patient ischemic stroke or TIA who are obese, you want to refer to an intensive multi-component life behavioral modification program to achieve sustained weight loss, which is the important sustained weight loss. So this would mean an exercise regimen, a diet regimen, maybe changing the food available in the house, maybe changing the way people eat at home. But you want a comprehensive program. You might have to do some psychological counseling, psychiatric therapy, and might even may want to consider drugs and pharmacological therapy for weight loss. You want to calculate BMI at the time of their event and thereafter to screen for and classify obesity. I think this goes pretty straightforward. BMI is very, very often calculated simply because they have to take the height and weight of patients when they come in. Remember, in patients who undergo very, very specific recommendations and intensive program, about 25% of patients will lose more than 15 kgs in these programs, and in about 50% of the patients who lose this way their weight will very often put their diabetes, if they have it, into remission. And then finally, coming to the part that is very important, and one of the reasons why I believe you all are here is the pharmacotherapy. The reason I put pharmacotherapy at the end is because I wanted to show you all the other things that you could do that are also very, very effective in reducing risk of stroke. And now coming to use of antiplatelet and anticoagulant agents. First, we will do the risk stratification of TIA with the ABCD3 score. What is A? A is age, that is 1 point. Age more than 60 is 1 point. B is blood pressure, systolic more than 139 or diastolic more than 90 is 1 point. C stands for clinical condition. Speech impairment without weakness is 1 point. Weakness on any side is 2 points. And finally, D. D has three types. There is D, which is duration. A TIA of less than 90 or less than 60 minutes is 1 point. More than 60 minutes is 2 points. The second D is diabetes. Presence is 1 point. The third D is dual TIA. That is, you get a second TIA within 7 days. That is equal to 2 points. Other findings that we should get is the 3D3 and the I. If you have ipsilateral stenosis of ipsilateral, that is same sided or more than 50% stenosis of ICA, internal carotid artery, is 2 points. MRI showing hyperintensity on diffusion weighted images is 2 points. Why? An MRI showing a hypointensity on DWI implies it was not a transient ischemic attack, which is a symptomatic diagnosis, but you have imaging or radiographic confirmation of stroke. If you do this score, a score of 0 to 3 means a 90-day chance of stroke of under about 3%, so 1 in 30. An intermediate score of 4 to 7 means a risk between 3 and 6%, that is 1 in 16. And a score of between 8 to 13 is a high risk for recurrent stroke. That is more than 18% in 90 days. That means you're about 1 in 5 to 1 in 6 people will have a recurrent stroke in under 90 days and 3 months. 3-month risk of recurrent stroke. So, what are some general rules or protocols that we follow in order for secondary prevention? Green is you should do, orange is you can consider doing, and red means do not do. Green: antiplatelet therapy is indicated in preference to oral anticoagulation to reduce the risk of recurrent stroke in patients who do not have cardioembolic stroke. So, in non-cardioembolic stroke, antiplatelet therapy is indicated in preference to oral anticoagulation. For non-cardioembolic stroke or TIA, aspirin between 50 to 325 milligrams daily or clopidogrel 75 mg daily, or the combination of aspirin 25 and dipyridamole 200 milligrams is indicated. For patients with minor stroke, that is NIH scale less than 3, or a high risk TIA from a non cardioembolic stroke. What is a high risk TIA? ABCDD2 score is more than 4, or an ABCDD3 score of more than 8. You want to give dual antiplatelet therapy, that's aspirin plus clopidogrel, for within 24 hours of symptom onset, preferably within 7 days, at least within 7 days, and continued for up to 90 days, followed by single antiplatelet therapy to reduce the risk of recurrent stroke. For a moderate stroke, that NIH score less than 5 and high risk TIA, and you have a stenosis of more than 30%, you might want to consider dual antiplatelet therapy with aspirin plus ticagrelor, which in India is sold as Brilinta, to reduce the risk of 30-day recurrence of stroke. But understand, using ticagrelor is associated with increased risk of bleeding, including intracranial hemorrhage. For patients already taking aspirin at the time of the stroke, you can consider adding a second agent, though the efficiency or the benefit of this is not well demonstrated. However, red, do not do dual antiplatelet therapy for more than 90 days. There is no benefit with increased risk of hemorrhage. Let's talk about lacuna stroke, small vessel occlusion. You want, so we discussed, like we discussed over here, for any stroke, you want to give antiplatelet therapy with either, you can give either aspirin or ticagrelor, or aspirin or clopidogrel. Okay, but in lacunar stroke, adding cilostazol for secondary stroke prevention is uncertain. You can add it, but there's no evidence of benefit, but definitely no harm. What is cilostazol? It's a non platelet inhibiting drug that is shown to improve, uh, decrease the risk of thrombosis, especially in small vessels. In patients who have intracranial disease, what does this mean? You have signs of stenosis of your internal carotid artery or middle cerebral artery, anterior cerebral artery, or posterior cerebral arteries, or within the basilar arteries. So, with that in mind, in patients with stroke or TIA caused by 50% to 90%, 99% stenosis of a major intracranial artery, you want to give 325 milligrams of aspirin in preference to warfarin. In patients with recurrent stroke or TIA within 30 days, you can add clopidogrel to aspirin for up to 90 days. In patients with recent stroke or high risk TIA and more than 30% stenosis on the same side, consider adding ticagrelor 90 mg twice daily to aspirin for up to 90 days. Though be aware, you might run a higher risk of having ICH, that is intracranial hemorrhage. In patients stroke or TIA due to a 50 or 99% stenosis of a major intracranial artery, consider adding cilostazol 200 milligrams per day to aspirin or clopidogrel. In patients with stroke or TIA of with 950 to 99% stenosis, clopidogrel alone, the combination of aspirin and dipyridamole, ticagrelor alone, or cilostazol alone is not well determined. So basically, do not use this combination. Go to aspirin, and if it's a high risk stenosis, you can add clopidogrel or ticagrelor to aspirin. Risk factor management. In patients stroke or TA due to a 50 to 99% stenosis of a major intracranial artery, maintain blood pressure below 140. You want to do high intensity statin, moderate exertion, physical activity are recommended to prevent recurrent stroke. This is a level green evidence. And angioplasty stenting with severe stenosis, 70 to 99% of intracranial artery, and actively progressing symptoms of recurrent TIA. You want to do BP control, high intensity statin, who are already on all of this. The usefulness of angioplasty or stent placement to prevent ischemic stroke in the territory is unknown. Why is this? Because even though you might open up the artery, there is a significant risk of bleeding or stroke from the procedure itself, or a risk of hemorrhage due to the procedure. Because very often when you give stenting and you have to do these procedures, you have to give heparin to these patients as well. In intracranial disease, do not do these. These are known to cause harm or no benefit. Stroke or TIA due to severe stenosis of a major intracranial artery. Angioplasty or stenting should not be performed as an initial treatment. You can do it later once the patient is stable, but not as an initial therapy, even for patients who are taking antithrombotic agent at the time of stroke or TIA. In the patient's stroke or TIA due to moderate stenosis, so less than 70%, but more than 50, angioplasty or stenting is associated with excess morbidity and mortality compared to medical management alone. So, if more than 70%, you can consider doing it on a delayed event, but not right now. In less than 70%, do not do it. It is more excess morbidity and mortality compared to just maximal medical therapy. What is maximal medical therapy? Blood pressure less than 140, high intensity statin therapy, and moderate physical activity, in addition to stop smoking and good quality diet. In patients with stroke or TIA due to 15 to 99% stenosis, extracranial to intracranial bypass is not recommended as to prevent strokes. So this is not really recommended. A lot of people not do it, but it's in the guidelines. So I thought I'd show it to you. Atrial fibrillation guidelines. The reason this is separate because this is a cardioembolic stroke. So and a large percentage of people who do have strokes will very often have cardioembolic strokes. So with that, what are the green quality of evidence? In patients with non-valvular atrial fibrillation and stroke, oral anticoagulation, apixaban, dabigatran, endoxaban, rivaroxaban, or warfarin is recommended. Atrial fibrillation and stroke and TIA, oral anticoagulation is indicated to reduce the risk of recurrent stroke regardless of whether the AF is paroxysmal, persistent, or permanent. Doesn't matter if they have AF for 10 minutes or they're permanent AF, you would want to start oral anticoagulation. In patients who do with stroke and TIA and atrial fibrillation who do not have moderate to severe mitral stenosis or mechanical heart valve, basically in non-valvular AF, apixaban, dabigatran, endoxaban, or rivaroxaban, together they are combined DOAC, direct oral anticoagulation, is recommended in preference to warfarin. In patients of atrial flutter and stroke, anticoagulation therapy is the same as atrial fibrillation. In patients with atrial fibrillation and stroke, without moderate to severe mitral stenosis or mechanical heart valve, who are unable to maintain therapeutic INR with warfarin, you want to use dabigatran, rivaroxaban, apixaban, or edoxaban. So, or DOACs. We'll just say DOAC from here onwards. So, I'll make it simple. If you have atrial fibrillation, you want to use oral anticoagulation, preferably with a DOAC. If you have valvular AFib, which means you have mitral stenosis or a mechanical heart valve, you want to use warfarin. Okay, simple. Now, coming to yellow and orange data. In a stroke with a high risk of hemorrhagic conversion, you can delay the onset of oral anticoagulation therapy beyond 14 days to reduce the risk of ICH. Remember, big stroke, big risk of bleed. In TIA, in the setting of non-valvular AFib, it is okay to initiate anticoagulation immediately. So if you have TIA, you find them AFib, you can start immediately. But if they have a big stroke or a high risk of hemorrhagic conversion stroke, you can wait up to 14 days. In patients with stroke or TIA and they have a contraindication to lifelong anticoagulation but can tolerate a short period, about 45 days or 6 weeks, You can do a percutaneous closure of the left atrial appendage with the Watchman device. And for that, you need to, after you place Watchman device, you need to do 45 days of anticoagulation. You can consider this. In patients who have a stroke with a low risk of hemorrhagic conversion in the setting of AF, you can start anticoagulation between 2 to 14 days if they have low risk of hemorrhagic conversion. In patients with AF and stroke who have end-stage kidney disease or on dialysis, your options are either warfarin or apixaban. Valvular disease. So if you have valvular disease, then what are your recommendations? So these are patients with stroke and valvular AFib. So that's moderate to severe mitral stenosis or any mechanical heart valve. Your drug of choice is warfarin. With mechanical mitral valve and a history of stroke before the valve replacement, aspirin is recommended in addition to warfarin with the INR of 2.5 to 3.5. In patients with non-ischemic stroke or TIA and native aortic or rheumatic valve who do not have AF or any other indication of anticoagulation, antiplatelet therapy is okay. What does this mean? So if you have a stroke and you have a native aortic or non-rheumatic mitral valve disease, which means you have mitral valve prolapse or, uh, mitral prolapse or non-rheumatic mitral valve disease, just antiplatelet therapy is okay. If you have aortic valve disease, you give antiplatelet therapy. In patients with bioprosthetic aortic or mitral valve, a history of ischemic stroke or TIA before valve repair, and no other indication for anticoagulation therapy beyond 3 to 6 months from the valve replacement, antiplatelet therapy with aspirin is recommended. What does this mean? It means if you have a history of TIA and stroke, and if you need a bioprosthetic aortic and mitral valve, normally after bioprosthetic aortic or mitral valve, they'll give anticoagulation therapy for about 3 to 6 months. And after that, you can switch to just normal antiplatelet therapy with aspirin. Here are some orange and yellow and orange and red indications. Ischemic stroke who have recurrent emboli and persistent vegetations, early surgery is recommended to prevent further strokes. Patient with ischemic stroke and TIA and mechanical aortic valve, anticoagulation with high intensity warfarin is beneficial with, or you can add aspirin to reduce the risk of cardioembolic events. In patients with ischemic stroke and left-sided endocarditis with a vegetation of more than 10 millimeters, you want, before completion of full course of antibiotics, early surgery may be indicated to prevent further stroke. However, if you are doing early surgery, make sure they do not have large risk of intracranial hemorrhage. Okay? In patients with ischemic stroke and TIA, early valve surgery before completion a full antibiotic course of antibiotic is considered in patients with an indication of surgery who have no evidence of intracranial hemorrhage or extensive neurological damage. With infective endocarditis and major ischemic stroke, delay valve surgery for at least 4 weeks may be considered for patients with infective endocarditis and major ischemic stroke or intracranial hemorrhage if the patient is hemodynamically stable. So let me just, this is a little confusing, so let me make it easier for you. If you have a large vegetation, consider doing early surgery if there's no evidence of stroke. In patients who have a large is end vegetation, only do surgery early if there's no evidence of extensive neurological damage or no intracranial hemorrhage. If, however, they already have a large stroke, then you want, or they have intracranial hemorrhage, you want to wait at least 4 weeks and then consider doing surgery. And then patient with ischemic stroke and TIA and mechanical heart valves, if you give treatment with dabigatran or for that matter any DOAC, it is associated with more harm than benefit. So do not do that. Quickly to summarize this is a quick flow chart. If you have atrial fibrillation and any mechanical valve or moderate to severe mitral stenosis, you want to use warfarin. For everything else, you can use a DOAC. If you're in sinus rhythm, non-rheumatic valvular mitral valve disease, antiplatelet, aortic valve disease, antiplatelet, bioprosthetic mitral valve or aortic valve, antiplatelet. But if you have in sinus rhythm in any mechanical valve, that is mechanical mitral valve or aortic valve, you want to go to warfarin. If despite that you're having recurrent stroke or TIA, rule out non-valvular causes, assess bleeding risk, and consider intensifying. So go to higher INR. So that is instead of INR 2 to 3, you go to INR 2.5, 3.5. And finally, endocarditis. If you have intracranial hemorrhage or major ischemic stroke or big stroke, yes, delay surgery 4 weeks. If no, mobile vegetation more than 10 millimeters, yes, early surgery. If no more, if recurrent emboli despite antibiotic therapy, go for early surgery. However, there's lots more to cover, but we will do that for another time. Thank you so much, and look forward to your questions, if any. Thank you. Ankana, you're muted.
Thank you so much, sir, for your comprehensive talk, and the PPT was so much informative. Sir, we have received few questions from our participating doctors. With all your permission, can I put them across? Hello, am I audible?
Yes, you are. Sorry, I was muted. I was saying yes, please go ahead.
Okay. What are the primary antiplatelet agents used in the secondary prevention of stroke, and what are the indications for each?
So I think I've already covered this question in our talk. I'll just say the main agents are aspirin between 75 to 100 milligrams, clopidogrel 75, aspirin is once daily, clopidogrel 75 milligrams once daily, and tigagrelor 90 milligrams twice daily for patients who have very high grade stenosis, that is 70 to 99% stenosis in the intracranial artery.
Okay, we are moving to the next question, that is, when is combination therapy with aspirin and clopidogrel indicated, and what are the potential risks?
So again, I think I've already covered this in my presentation, but once again, in patients who have a moderate size stroke, so that is NIH score of less than 5, or a high grade TIA, that is a ABCD2 score of more than 4, or a ABCD3 score of more than 8, then you want to go for dual antiplatelet therapy for up to 90 days. And after that, you want to do single antiplatelet therapy.
Okay, we are moving to the next question, that is, what are the recommendations for lipid management in patients who had a stroke?
Again, we have covered this in our presentation, but I'll tell you the official guideline is LDL if they have no other risk factor and only stroke, LDL less than 100, and if they have other indications, other high risk factors in addition to stroke, then less than 70. However, personally speaking, I push for less than 50. Okay, just because these people get older and their adherence is not good, I start with high intensity statin. I might add ezetimibe if I'm unable to meet my goal. Another good drug you can do for people who are intolerant of statins is bempedoic acid, which is now on the market.
Okay, moving to the next question, that is, how does optimal management of diabetes contribute to the prevention of recurrent stroke?
So, like we know, diabetes is a disease. It has significant vascular component. If diabetes accelerates atherosclerosis, so with the acceleration of atherosclerosis, you have, of course, an increased risk of stroke. And diabetes, at the end of the day, is a metabolic disease. So what does this mean? Insulin resistance causes hypertriglyceridemia. One of the treatments of triglyceride is increasing the amount of insulin. So treatment of diabetes, a low carbohydrate diet, avoiding fats and avoiding a high fat diet, avoiding added sugars, refined sugars in diet, Diabetes control will decrease the rate of vascular degeneration, decrease the rate of atherosclerosis and progression of atherosclerosis and new atherosclerotic lesions inside the brain. And that will indirectly lead to improved cardiovascular outcomes.
Okay, we are taking the last question for today's session, that is, how do you ensure adherence to secondary prevention therapies in stroke patient, and what strategies can improve the compliance?
So at the end of the day, you need to have a detailed conversation with either the patient or the patient caregiver to what are their goals, and make sure that your treatment is in line with their goals. um, what is the level of function, and then you have to design a strategy that works around the level of function, right? So if they have a stroke with significant with significant deficit, you cannot tell them to do vigorous exercise. You might need to arrange for a inpatient rehabilitation, or physiotherapist or a cardiac rehab person to go to their house and help them with exercise. You can't tell them to take a low salt diet if everybody in the house is eating a high salt diet. So you need to then counsel everybody in the house. You can't tell them to avoid sweets when dessert and rasgulla and gulab jamun is being made and or given at home, or there are young kids with the 2 liter Pepsi bottle, the Coke bottle sitting at home. So then you have to have like a group therapy. You can't tell them to quit smoking when there are two other smokers in the family, and the person is you're telling them to quit smoking, and two other people are busy smoking in the house. It's not going to work. So you have to take the entire family along with you, and you need to have very often you need to have group discussions with family on what to do and how to do.
Thank you so much, sir, for answering all the queries of our doctors. And I'd also like to thank all the participating doctors for your continuous participation at the platform. Thank you once again, sir, for your valuable time and for being with us at the platform and sharing such valuable insights with us. So, with all your permission, can we just stop the live here?
Yes, perfect. Thank you, and thank you to the entire audience for coming and giving us time on your weekend. Thank you, and have a good day.
Thank you, sir. Thank you so much.